the virtual general meeting
Sorry.
hosted by the UCLA Alumni Association. The guidance and support from UCLA Alumni Association. During this academic year, enabled FWC to complete several major tasks, including our online membership application system and resource information sharing through the Alumni Connect newsletter. Between last July and this February, we have successfully hosted 3 general meetings, including the presentation of FWC Women of Distinction Award and the scholarship dinner held on February 4th. But since March, we have had a difficult and disruptive time caused by the pandemic. With the safety and the health of FWC members as our first priority, we had to cancel March and April general meetings. However, our board and the sections still remain quite active through conference calls, teleconferences, emails, as well as e-blast. Furthermore, we had formed an ad hoc committee to cope with the COVID-19 virus crisis, to help our members maintain their spirits and personal connections affected by social distancing. The ad hoc committee has promoted various approaches for our members to maintain their FWC connections. For this afternoon, we are very honored to invite Dr. Shira Shafir as our guest speaker. Her topic is updates on COVID-19, what you need to know. Now, I would like to welcome Helene Derousseau, Program Chair and Moderator, to introduce Dr. Shafir and lead today's program. Helene.
Thank you, Shirley. I would like to now introduce our speaker. Is there feedback? There we go. Is that better?
Yes.
I would now like to introduce our speaker, Professor Shira Shafir. The title of her talk today is Updates on COVID-19, What You Need to Know. Dr. Shafir is an associate professor in the Departments of Community Health Sciences and Epidemiology at the UCLA Fielding School of Public Health. She is also the director of the Master of Public Health for Health Professionals in the Department of Community Health Sciences and former assistant vice chancellor of research for ethics at UCLA. Dr. Shafir serves as the director of field studies for the Department of Epidemiology, where she mentors students through the internship process from application, selection, and completion to ensure they develop public health practice competencies to complement their methodologic training. An epidemiologist with expertise in neglected tropical diseases and infectious diseases of poverty, she holds an MPH in infectious diseases from UC Berkeley and a PhD in epidemiology, and completed a postdoctoral fellowship in global health from CHS at UCLA. She's developed and taught courses in responsible conduct in under-resourced settings, foodborne disease epidemiology, infectious disease epidemiology, global health and tropical medicine, introduction to epidemiology, principles of control of infectious diseases, and contemporary issues in public health. She has been teaching public health to undergraduate students for almost 10 years and has particular interest in introducing pre-med students to the field of public health. And she was voted Professor of the Year by the UCLA Public Health Students Association for 4 consecutive years. Dr. Shafir is currently working on the UCLA initiative in partnership with UCSF and the California Department of Public Health to train contact tracers and case investigators. I bet your students are in big demand right now. Dr. Shafir, I'm sure we will have many questions for you, so thank you for taking time to speak to us today. Dr. Shafir will speak for about 45 minutes, after which she will take questions. You can pose your questions by using the Zoom chat feature at the bottom of your screens after this presentation. Type them in and send them to the meeting host, and I will pose the questions to our speaker. She will answer as many questions as we have time for. So welcome, Dr. Shafir.
Thank you very much, and it's a pleasure to be with all of you. My very dear doctoral mentor, Larry Ash, his late wife, Luana Ash, was a fierce and dedicated member of the FWC, so it's an honor to be here, and I will sort of dedicate what I say to Luana Ash. So my intention over the next 45 minutes is to tell you a little bit of a story and draw some connections between what we know about this virus and what we don't know, and use that to sort of guide our own behaviors in order to make sure that each of us is being as safe as possible given the current situation with the virus. So one disclaimer, this presentation is current as of noon today, but what we know and what we understand about this virus changes so quickly that it's very likely that some of this will be out of date by tomorrow. So just a brief disclaimer there. My second disclaimer is that like all of you, I am currently working from home, but probably distinct from many of you, I am working at home with a toddler. So while it is currently his nap time, there's a chance he'll wake up in the middle of this presentation, meaning there's a real chance someone in this house is going to be screaming bloody murder. So everything's fine. Do not be concerned. And if a little blonde-haired child runs in, let's ask him questions about COVID too. So let's start at the beginning. So we first became aware in terms of a public health and infectious disease community of the existence of something unusual in late December of 2019. It was clear that there was an emerging viral pneumonia in Wuhan, China. And by January 2020, they had identified that this viral pneumonia was being caused by a virus that was subsequently named SARS-CoV-2. So severe acute respiratory syndrome, coronavirus number 2, with the first one being the SARS that was detected in 2002, 2003 in China as well. It subsequently became clear that this was a very significant problem. They renamed the disease COVID-19, so coronavirus infectious disease emerged in 2019. Just to be clear, there were not 18 previous COVIDs, but rather that's just the year in which we first saw it. In just the first 3 months, so January, February, and March, nearly 1 million people were infected, the majority of whom were infected in China, but in other places around the world. And there were nearly 50,000 deaths. And that's really the point at which the WHO began to get very concerned. And in late January, they then declared that this was a public health emergency of international concern. And essentially what that means is they believed that there was a situation that surpassed any single member nation's ability to deal with it. So that's what the international concern means. You can further see, this is sort of evolution of the very early picture. Initially, it was believed that while this was a terrible infection, it was only among individuals who had contact with some of the wet markets in Wuhan. Subsequently, there were detected some cases that it was clear had never been to the wet market. So that indicated that there was a high possibility that it could be transmitted from person to person. And then we began to see that it was, despite the fact that they did decide to implement some travel restrictions in Wuhan and in the larger province of Hubei, it became clear that it was being transmitted in other places around the world. So as I mentioned, the majority of the first cases that were discovered appeared to have a link to a seafood and animal market. And so that did suggest that this was animal to person spread. So everybody was getting infected as a result of their contact with animals. Had it remained that way, this would have been a terrible infection for those who got infected, but we would have very easily been able to control this infection because we simply could have restricted contact with things like these wet markets. So we do know, based on a lot of epidemiologic evidence and also looking at the sequence of the virus, as well as what we know from other human coronaviruses, in particular SARS and MERS, that it is nearly certain that animals are the primary source of the outbreak. Unfortunately, right now, it's not 100% certain what animals. In general, when we think about coronaviruses, we think about Rhinolophus species of bats, but we don't actually believe that individuals are getting infected as a result of their contact with bats, but rather bats are infecting another animal, and then humans are getting infected as a result of their contact with this separate animal. So that might lead you to wonder, well, what in the world would this animal be? Currently, the best evidence that we have is that this virus, in fact, was spread as a result of contact with pangolins. So those of you who are not evolutionary biologists or ecologists have likely never heard of the pangolin. I would like to assure you that I did not deliberately choose a very unattractive picture. There, in fact, are not attractive pictures of the pangolin. It is a mammal, but what you are seeing in the photo, those are their keratinous scales. So their entire coat, and I apologize that I'm making a face that sort of indicates how I feel about them. Their entire coat is made up of the same material as our fingernails. So why in the world, if most of us have never heard of the pangolin, do we think that it is probably the pangolin that was the source of this infection for people? Well, in fact, pangolins are the most trafficked animal in the world. And it's largely because those scales are thought to have some value in traditional medicine, both in Asia and then in Africa. So they're being trafficked so that people can access the scales. One of the things we know about wet markets, and you'll also see these referred to as live animal markets, animals that are being kept there tend to be very stressed out. And when they're stressed out, they release these stress hormones that stress out the other animals around them. And then beyond that, it causes them to release more and shed more virus. So they, in fact, can be even more infectious when they're in these situations. So let's now turn to sort of what we know about the virus. On a global level, there have been more than 4.7 million cases of this infection reported to the World Health Organization. Now, something that's really important to note, this number is wrong. With certainty, I know that it's not correct. The problem is I don't know how wrong it is, and it's not just me, and nobody who does what I do knows exactly how wrong, because in order for a case to be reported to the World Health Organization, it has to be reported to the federal government in the country where it occurred. So here that would be the Centers for Disease Control. In order for the CDC to know about it, it has to be reported to a state health department. In order for a state health department to know about it, it has to be reported to a local health jurisdiction. So for us, that would be Los Angeles County. In order for the county to know about it, not only does someone have to actually make the report that a case has occurred, but the person has to be tested. And when we talk about testing momentarily, I'll show you how such a small percentage of people who probably should be tested are getting tests. So we know with certainty there have been more than 4.7 million cases. We just don't know by how much. Also important to note that there have been more than 250,000 total deaths reported as a result of this infection. Now, when we look at the domestic picture, here in the United States, there have been 1.48, so we are just shy of 1.5 million total cases. And we are also just shy of 90,000 total deaths as a result of this virus. I think what's really important to call out here, the United States has a little bit over 4% of the total world population, but we have nearly 1/3 of all the cases of COVID that have been reported, and we have more than 1/4 of all the world's deaths. So we are seeing a disproportionate burden here in the United States, and a lot of that is thought to be due to the very delayed response that we had, both in terms of availability of testing and strategies to support testing. The last thing I want to call out here, when we look at this map, this is actually reporting by rate. So now it's finally taking into account how many people are in a state. So it's not particularly relevant just to say we've had 70,000 plus cases in California. We certainly have, but we would expect to have more cases in California than they might have in Wyoming, for example, because we have so many more people. So rather than just reporting total cases, and you can see here that there is the option to look just at total cases. When we look at rates, it sort of gives us a sense of how bad a problem is in a population. So in that sense, California is a little bit in the middle of the pack. We're certainly nowhere near where Wisconsin, Louisiana, and New York are with respect to this outbreak. So when we look at our domestic picture, here in the state of California, we've had over 80,000 total cases that have been diagnosed and reported. Again, that's not correct, but we don't know by how much it is wrong. It's important to note when we look at the ages of the cases, the majority of people have been between the ages of 18 and 49. When we look at who's getting really sick, however, that's going to be a very different picture. Another important thing to note is that cases are slightly more likely to be male than female. This is true throughout the world, and right now we don't know if that's because males are more likely to engage in risky behaviors like going outside without having masks on or poor hand hygiene, or if maybe there is a slight protective effect of femaleness that perhaps comes through some of the female hormones. So I guess maybe there is an upside to those. I don't know. You can see as well of the 80,000 total cases, roughly 3,000 of them have been hospitalized and another 1,000 have needed the ICU. And there have been 3,302 fatalities ascribed to this virus. The other relevant thing to note, when we look at that picture in California, it's pretty clear looking at the size of those purple dots that Los Angeles does bear the greatest percentage of the burden of new COVID cases. So the state of California is doing a lot of really great work with data visualization. And one of the things they're trying to show here, what you can see in blue is how many cases we have had. And when you look at black, you can see how many deaths have been ascribed to the virus. And potentially the most relevant thing here is to look at the gray line in each picture. So for example, when we look at positive cases by age, in the 18 to 49 group, that group is overrepresented in terms of total number of cases with respect to the percentage they represent in the California population. We can also see that when we look at race ethnicity, the Latinx population is disproportionately overrepresented in total number of cases. Over half of the cases in California are being diagnosed in individuals who are Latinx. Now, when we turn our attention to the total number of deaths, we in fact see a very different picture. So 56% of all the deaths are happening in men. So men, in fact, in California are more likely to die from this infection than women. We also see when we look at deaths by age that there is a really significant overrepresentation of deaths among those who are over the age of 65. So nearly 80% of all the deaths in California are in this higher risk population. The other thing that's important to note when we look at deaths by race and ethnicity, and this is true throughout the entire country, while we saw the greatest number of cases in the Latinx population among the Black population and the Native Hawaiian and Pacific Islander, we're seeing a much greater proportion of deaths. So we believe a lot of that is due to issues with access of care and social determinants of health. There's nothing sort of genetic that predisposes any particular racial or ethnic group to have more severe disease, but rather we see a lot of those other determinants that are affecting the populations and resulting in very poor outcomes. So let's talk very briefly about what this virus looks like in the people who get it. And this is really a story of constant evolution. When this was first discovered, the Centers for Disease Control and the World Health Organization talked about really a triumvirate of symptoms. It was fever, cough, and shortness of breath. As we have had more and more cases, one of the things we're recognizing is that this virus can look very, very different in different people and different populations. So most recently, the CDC updated their symptoms to say it could be cough, it could be shortness of breath or difficulty breathing, or we should have a high index of suspicion. We should seek out testing and be concerned if someone has at least two of the following: fever, chills, repeated shaking with chills, muscle pain, headache, sore throat, and then finally, new loss of taste or smell. When you look at these symptoms, one of the things you may note is there's nothing very specific there. My guess is sometime in the last few years, you've had at least one or more of those symptoms, and you probably didn't have COVID. So these are very nonspecific, and that unfortunately makes it very, very difficult to know if an individual may be infected, with the exception of running laboratory testing. The one exception to that is loss of taste or smell. And in fact, that seems to be fairly specific. We don't see a lot of loss of taste in the population otherwise. So if you or someone you love can't smell their morning coffee, it's probably a very good idea to call the doctor and make sure you can be tested. And if you're not drinking, by the way, drinking coffee, then I'm just not sure how you're doing this. So there's a lot of information on this slide. The take-home message is, while those are the symptoms we talk about most often, it is recognized that people are presenting with symptoms that are unusual. And so anytime someone doesn't feel well and there isn't another explanation, we really should be considering potential diagnosis of COVID-19. And in particular, there are individuals who are having nausea and diarrhea as their only symptoms and nothing else. When we talk about this disease, it's important to talk about who's getting sick and how sick are they getting. So this is sort of a famous image in epidemiology. We talk about icebergs. And what you see at the bottom of the pyramid is asymptomatic or mild cases. So ultimately, we think that probably about 1 in 5, 20% of people who are diagnosed, who are infected with COVID-19 don't develop symptoms of infection. So we don't ever test them. We've had to do a lot of studies in order to try and figure out who those individuals might be. Unfortunately, we do believe those people can be infectious. So that's one of the reasons we have all these population-based control measures that we'll talk about at the end. Now, roughly 80% of people will fall into that symptomatic general bucket. They'll be mild to moderate. And it's important to note that when the Centers for Disease Control says mild to moderate, essentially all they mean is someone who's not sick enough to go to the hospital or sick enough to require hospitalization, but many of the people who fall in this group feel very, very sick. And then something like 14 to 15% will require hospitalization, and then about 5% of individuals will require intensive care, and very often that also means they require mechanical ventilation. So what does that then mean? Who is at greater risk to be in the symptomatic group, to be in the severe group? Right now, we know that individuals who are over the age of 65 seem to be at higher risk. Anybody who lives in a nursing home or long-term care facility seems to be at increased risk of infection. There are other risks, including chronic lung disease and moderate to severe asthma. And I just want to clarify this one because my guess is there's someone who is participating in this webinar who either has asthma or who has a loved one who does. When we talk about moderate to severe asthma, we're really talking about someone who is having complications as a result of their asthma on a daily basis. So not someone who has well-controlled asthma who occasionally uses a rescue inhaler, but really someone who is having consistent difficulty in breathing. We also include anyone who has heart disease with complications, anybody immunocompromised, including people who are undergoing cancer therapy, people of any age who have a BMI over 40, and then uncontrolled medical conditions like diabetes, renal failure, and liver disease. While with other viral respiratory infections, we do see that individuals who are pregnant are at increased risk. We have not seen that yet with COVID-19, and there's a lot of research that's being done to try and track that. So we are assuming that people who are pregnant could be, even though we haven't seen evidence to support that as of yet. So as I said, about 80% of people were going to be mild to moderate. When we look at the mortality experience from this virus, it's important to note that when we talk about case fatality in general as being 2 to 3%, what that means is between 2 and 3% of everybody who is sick enough to be diagnosed with this infection, about 2 or 3 out of every 100 people will end up dying from this infection. But what we then subsequently understand is the chance that someone who is mild to moderately sick will die is infinitesimally small. Whereas when we talk about individuals who are critically ill, who are in ICUs and requiring mechanical ventilation, In general, we do see that over half of those individuals will die as a result of this infection. So by the time someone is sick enough to require hospitalization, we do see that this infection is very, very serious. So let's now talk briefly about what we know about how this virus is transmitted. And the reality is we're still learning a lot. But in general, we think that the majority of transmission occurs from person to person via respiratory droplets. And my guess is everybody has heard some of the pontificating and discussions about this. But when we talk about respiratory droplets, it's particles that are very heavy. So they tend to fall fairly quickly. So in general, what we think is you have to be within about 6 feet or 2 meters of someone in order to catch something through respiratory spread. We do also think that spread is possible through fomites, which is someone coughs, they spread their droplets onto an inanimate object or surface. The virus can then survive on that surface. And depending on the type of surface, it may be able to survive as long as 72 hours. So anytime someone touches something and then touches their hand to their mouth, their nose, their face, they're potentially going to introduce that virus. That's the reason that we're so adamant about good hand washing, because if you do touch something, you want to make sure that it's then removed from your hands before you end up subsequently touching your hands close to your face. The other very important thing to note is that this virus, we believe, can be transmitted by individuals who lack symptoms, who will never develop symptoms. That's who we would talk about as asymptomatic. We also think it can be spread pre-symptomatically. So when I teach, I talk about this as the ABC period, asymptomatic but communicable. So that's a period of time when an individual has not yet developed symptoms, but they are capable of transmitting the virus. And we actually believe that someone's viral load might be highest during this period. So in fact, people would be most contagious before they even know that they are infected, which is a big part of the reason we're relying so heavily on social distancing. It's why we're asking everybody to wear masks when they're outside, because that essentially protects the world from the mask wearer. So just in case someone is asymptomatically infected, sort of keeping their viruses to themselves. It's likely that you've heard some discussion of this idea of an R0. So the R0 is the reproductive number. And that's the number of people on average that each infected person goes on to infect. Our best estimates right now are that this is somewhere between 2 and 3. So in the absence of social distancing, in the absence of a vaccine, in a circumstance where you have an unlimited number of people who could get infected, we believe that each infected person may go on to infect 2 to 3 more susceptible people. You'll also hear reference to the R. So that's sort of the effective number. And that takes into account some of the public health measures that we're utilizing. And sort of the catchphrase about R is that we have to get R below 1, which means what we're trying to achieve is that each infected person infects less than 1 person to replace themselves, which would mean that transmission would die out. Just to put this in context, COVID is not the most infectious disease by a lot. Diseases like measles have an R0 between 12 and 18. So every person with measles, if they come into contact with a susceptible population, could infect between 12 and 18 more people. What we think is the issue here is not just that the R0 is fairly high, although nowhere near as high as what we see for a disease like Ebola, for example, but it is possible to transmit before symptoms, which really facilitates the transmission of the infection. We believe that most people will develop symptoms within about 5 days of their exposure, but we think it could be as short as 2 days and as long as 14 days. So if you've ever wondered why we've said that quarantine has to happen for 14 days, we take the absolute outside range of the hypothetical incubation period and we utilize that. So essentially we're saying if we think someone may have been exposed to a person who is infected with COVID-19 and who is infectious, we have to wait 2 full weeks to say if they will subsequently develop symptoms and see if there's a chance that they will be infectious to others. So the only way we know who is infected is to probably the single greatest limiting factor in the United States. We do not have enough tests. So we don't have enough physical materials for tests. We don't have enough of the swabs that are necessary in order to collect the specimen. We don't have enough of the reagents. We don't have enough people to perform these tests. And so what you're seeing here is this is the guidance from the Centers for Disease Control about who should be tested. So a couple of things are important. The highest priority is to test individuals who are hospitalized with symptoms. And that's really important so that number one, we can have good infection control in hospitals. We can make sure that we are sort of containing infections appropriately and not exposing additional patients. It's also really, really important to ensure that these individuals are receiving appropriate care, to know why they're in the hospital. We also have in the high priority group only people who have symptoms or people who have been identified by public health. The priority group is people who have symptoms, but they're not sick enough to require hospitalization, and people who don't have symptoms only if they've been prioritized by health departments. So you'll notice that there's nobody who's saying everybody who could possibly be infected should be tested right now. Countries that have had huge success in controlling their outbreak are those that have really leveraged testing, and then they've leveraged other public health measures like contact tracing and case investigation. So trying to figure out once someone is diagnosed with whom they might have come into contact so you can convince those individuals to go into quarantine. Just so you can see, the testing that we most closely rely upon is called nucleic acid amplification. So it looks for the presence of viral RNA. So it says if an individual has virus present, even in very small amounts, these techniques are going to amplify and create more viral genetic material so that we can subsequently find it. Oftentimes people are taking it's 3 to 4 days to get those results back. And so you can imagine that's a very stressful period when someone is either very ill or they believe they've been exposed. One of the real downsides of this nucleic acid amplification technology, it cannot tell us if someone is infectious, and it does not tell us if the virus is alive. So perhaps over the weekend you heard about the case of the USS Roosevelt, where they believe individuals were reinfected. In all likelihood, we have no idea right now if people can be reinfected, but in all likelihood, what happened is they simply found dead virus. And then this test simply amplifies virus, doesn't care if it's alive or if it's dead. So it's worth noting that we have a lot of questions, obviously, but one of the questions is about some of the serologic tests. So rather than taking a swab and looking to see if someone has virus, can we look to see if the body has mounted some sort of a response to the virus? Probably our two biggest questions in this area, we want to know if people develop protective antibodies. So do they make these proteins that help them respond to the presence of the virus? And number two, if they do develop these antibodies, how long will they last? Because that'll be incredibly important to understand how long, if people are protected, and if so, for how long. These serologic tests that we have look for two types of antibody molecules. The first is IgM, and importantly, when we first get infected with any sort of microorganism, the first thing we make in response is this IgM. It's sort of the immediate response. It helps to vanquish the virus, but then it goes away. We then subsequently create sort of a memory process, and that is IgG. So if we want to know if someone is newly or recently infected, we look for IgM. If we want to know if someone was infected in the past and may have protection, we would look for IgG. So the PCR only says, do you have virus right now? These serologic tests can tell us, was someone exposed in the past? Do they have some level of antibody? The other reason that these antibody tests are going to be so important is because they may help provide the foundation for COVID-19 treatment. There are currently trials going on, including one that's being conducted through UCLA Health, where we can try and collect these antibodies that have been produced by people who've recovered. And sort of famously, Tom Hanks and Rita Wilson, who were infected in Australia and then recovered, they have given their blood through the UCLA Blood and Platelet Center in order to try and filter out and collect these antibodies that can be given to people who are very sick And that sort of helps borrow immunity. So it helps someone get through the crisis until perhaps their body can mount its own response. We have to have good antibody tests to know from whom we should be collecting this convalescent plasma. So just so you can see in the universe of testing, it's not just that we don't have enough tests, that we don't necessarily have the right kind of tests, because when we look at the entire natural history or the spectrum, there are a lot of different questions we want answered. We want to be able to monitor contacts of people who are infectious. We want to be able to make treatment decisions. We also want to know, after someone has recovered, when is it safe for them to continue to engage with the population? And in particular, when is it safe for their family members to come close to them? So right now we're doing the nucleic acid amplification, swabbing the nose, and there are all kinds of reports. We need someone to get 2 consecutive negatives 24 hours apart. So you'll have someone positive, positive, negative, positive, 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 and it will be many, many tests until we feel confident that it's safe for that person. So it's not necessarily the right test, it's just the only test we have right now. What I will say is it is absolutely remarkable. We are less than 6 months into knowing of the existence of this virus. The fact that we do have tests available at all is just a testament to science and a testament to the scientists who are working on this issue just 24 hours a day right now to continue to improve the availability of the information we have. So you get tested, someone is infected, what do we know with respect to treatment? There are no FDA-approved drugs that are specifically for the treatment of patients with COVID-19. So what that means is it's really reliant on clinical management, infection prevention, supportive care, supplementary oxygen, and mechanical ventilation when it's indicated. There's a tremendous amount of work being done to help identify if some of the drugs that currently exist also will work against this infection. But right now, we don't have great data that would suggest any of them do. And I didn't realize that this is something that has to be said, but hydroxychloroquine, while it is safe for the prevention of malaria, and it is safe and effective for individuals who have lupus or who have rheumatoid arthritis, those are people who are sick. So it is not a good idea to take a drug like hydroxychloroquine before we have evidence that indicates it is both safe and it's also effective in the prevention of this infectious disease. Just to give you a little bit of a sense about this is the same process for drugs and vaccines. So it first starts out with preclinical work. And so this is maybe cell lines in a petri dish. It is work that gets done in laboratory rats, and eventually it gets done in monkeys. When the initial evidence shows that a drug potentially could be effective, it moves into phase 1 trials. And phase 1 trials really look exclusively at safety. Now, as a bonus, they may start collecting information about efficacy. But phase 1 is really, we talk about it as first in humans. This is the first time an individual, a person will have ever been exposed to this drug. And largely we're looking to see if it's safe. Drugs that pass through phase 1 go into phase 2. So phase 2 starts to look at whether or not the drug appears to be effective. And it's only when a drug passes to phase 2 that it can go to phase 3, where we begin to look at true efficacy in the population. It's important to note that about 60% of drugs that pass to phase 2 don't pass to phase 3. They don't have efficacy in people, as the laboratory and animal testing would have suggested. When we are repurposing drugs, so for example, if we're taking a drug like hydroxychloroquine that has already been shown to be safe, we can start in phase 3 trials. So now we just look to know, is it effective at treating this specific condition? So you'll notice that, for example, hydroxychloroquine is in phase 3 trials. There's a drug remdesivir that maybe you've heard about that just got emergency use authorization. There's also famotidine is in a phase 3 trial. So scientists are working around the clock to try and identify anything that might have a molecular mechanism that is similar to what we would need to see for the SARS-CoV-2 virus, and they're trying to see if they can repurpose those drugs. But right now, there is nothing that has made it through FDA review, confirming that it is both safe and effective, and it should be on the market for the use of this condition. It's also important to note that right now, there's no vaccine. So yesterday, there were some very encouraging results from Moderna. They are one of the 100+ trials that are in the field looking to see if we can develop quickly an effective COVID-19 vaccine. But while it was promising and they're moving to phase 2, it's really important to note that there were 8 total participants in that trial. So it was safe in 8 people, but I see that Dr. Afifi's wife is here, so one of my old biostatistics professors. So one of the things that I'm sure he would like me to reinforce, if something is a complication in 1 out of every 100 people, we are statistically unlikely to see it if we're only testing 8. And in fact, we're going to need much larger sample sizes to truly know if this is safe, let alone to really understand if it's effective. So a glimmer of hope, but I think we'll just call it a glimmer at that. Until we have a vaccine, the whole story for COVID-19 is prevention of exposure. So what does that mean? Washing your hands often with soap and water for at least 20 seconds. And I know you've heard this all before, but I'll also reinforce 20 seconds is longer than you think it is. So there are a number of songs depending on your preferred musical genre, but you can sing the chorus of Jolene by Dolly Parton. You can sing Happy Birthday to Yourself 2 times. If you're feeling really bold, you can sing the chorus of Truth Hurts by Lizzo. But it's 20 seconds, and we really need that mechanical action with soap and water to help wash away the virus. As a backup option, if soap and water are not available, alcohol-based hand sanitizer can be an effective option, but it should have a concentration of at least 60%. Soap and water is always preferable, but for example, if you are out grocery shopping, you'll want to use alcohol-based hand sanitizer when you come home. Don't touch your eyes, your nose, or your mouth with unwashed hands. Avoid contact with people who are sick. While we do know that individuals who are asymptomatic can transmit, don't come into contact with people who are sick before you know exactly with what they are sick. That includes for yourself, you need to stay home if you're sick, cover your cough or sneeze with a tissue, throw the tissue in the trash, and then really importantly, because we know that there is some role for surfaces, clean and disinfect frequently touched objects and surfaces. So not only are you going to wash your hands well after you have touched anything that someone's sneezing and coughing and talking could have come into contact with, but you also want to touch surfaces in your home. When we think about high-touch surfaces, it's going to be your doorknobs, your light switches, your sink taps, your toilet, your flush, countertops. It's not a bad idea if you have taken out your cell phone to wipe it down with a peroxide or a bleach-based solution, your credit cards, your keys. All of these things you need to see as sort of potential opportunities to bring the virus into your space, and you'll want to make sure that you're getting rid of the virus on those surfaces. So now I want to just turn a little bit to vaccine updates, and then finally we'll talk about sort of the population considerations. There are more than 100 different vaccines that are in development, both from private companies and universities across the world. Again, this is just a testament to science. It's a testament to scientists. The fact that we have known about this virus for less than 6 months and we already have candidate vaccines is absolutely amazing. By the same token, science can only go so fast. And if we cut corners, we could end up with a catastrophic situation where we have a vaccine, for example, that is not safe or it is not effective. So individuals might begin relaxing their social distancing because they believe they're being protected by a vaccine that doesn't actually work. There are at least 6 groups that have begun human testing of vaccine candidates. There's the Moderna vaccine that we talked about just a few minutes ago. There's the Oxford trial. At the very least, most of them are not going to enter into phase 2 studies until July at the earliest. And again, those phase 2 studies are going to be looking at the beginnings of efficacy. And then finally, we'll move to phase 3 where they start to look at, is it really effective when we give it to large numbers of people? The other thing to note about a lot of these candidate vaccines is a lot of them use technology that have never been previously used in a vaccine that has been brought to market. So I think we need to have some additional safety measures in place to make sure that we're really looking at once we know that vaccine is safe and effective, do we have the manufacturing capacity to make millions of doses of vaccine? And do we have the infrastructure in place in order to ensure that that vaccine can be distributed in an equitable manner? And all of that is going to be sort of the next phase of consideration. So let me talk to you a little bit about why we're all locked in our homes and why you're doing your first ever Zoom webinar for an FWC meeting. So this is an animation that was created by a microbiologist in Australia, which really talks about that notion of the R0. So this is an R0 of 3, right? So they're saying every individual who's infected will infect between 2 and 3 additional individuals. So what you can see is very, very quickly we have an exponential increase in the number of cases. But if we can socially distance, if we can break some of those chains, ultimately what will happen is we can manage the total number of infections. And so potentially you will have heard this referred to as flattening the curve. And this is an actual example from 1918 when the influenza pandemic occurred here in the United States, where you can compare the city of Philadelphia to the city of St. Louis. So the city of Philadelphia held a parade. People had a tremendous amount of contact. Their death rate from the infection skyrocketed. Whereas in the city of St. Louis, they implemented social distancing measures and they were really able to keep their number of cases manageable. And the real reason behind that manageability is so that everybody can receive the appropriate care. This doesn't decrease the virus's innate ability to cause death. So this doesn't decrease the case fatality rate, but it keeps it as low as possible because we assume we might see more cases dying if people don't have access to quality care. So we talk about this now as flattening the curve. So implementing these social distancing measures, washing hands, not touching your face, staying home if you're sick, wearing a mask if you have to go out in public, all of this will help prevent a high peak in the number of cases. And the real motivation behind that is to keep the number of given cases at any time below that dotted line. So that's below our healthcare system's capacity to provide the care that is necessary. What's important to note in this flattening is we don't actually successfully decrease the area under the curve. We're simply saying we're going to take the same area under the curve, the same number of cases, and we need to spread them out over a longer time. So until we have effective treatments, we're not going to decrease the area under the curve, and that's something that's really important to consider, particularly for individuals who are at increased risk of severe disease. We really want to make sure that they aren't going to become cases, because even if we have an ICU bed available, if we don't have something that can effectively treat them, they're going to have that increased risk of fatality. The other thing that's important to talk about, we're not just trying to flatten the curve, we're also trying to raise the bar. So can we implement measures that not just decrease the number of new cases we're getting at any given time, but also what are the ways that we have in order to provide more care to people? And this is a tremendous amount of ingenuity that's happened. Anyone who has been by UCLA Health may have seen the tents that are serving as triage facilities outside of the emergency room. There have been a lot of conversations about graduating medical students early, particularly in the Northeast, where they were hard hit very early on, really to provide additional capacity. There are devices that have been considered that you can mechanically ventilate 4 or 8 patients using one ventilator. So all of that would be attempts to raise the bar. So can we provide more cases and more care while we are also trying to reduce the total number of cases we have? I think the last 2 things that are really important to note, we have a lot of conversation now about the second wave. So if we have plateaued with respect to new cases in the United States, but we don't have a vaccine, we don't have a treatment, what's going to happen? And what you can see in red is we're now saying with near certainty, we are going to see a second wave from this virus. Our biggest potential issue is we don't want this second wave to come in the midst of flu season. And in particular, we know that flu season ends up taking a lot of hospital beds because people do get sick enough with the flu that they require hospitalization. So if we have hospital beds being taken by people with the flu, we have less hospital capacity. That's going to require all sorts of additional measures to try and raise that bar while we're simultaneously trying to flatten the curve. There are a couple other things that are really important to note here, though. We are expecting to see other waves impacting population health that are consequences of what we have been doing, but not directly as a result of COVID-19. So for example, we're expecting an influx of urgent non-COVID conditions. Here's my example. A couple weeks ago, I started to have some pretty significant discomfort when drinking cold beverages. Called my dentist said, yeah, you know what, this is an urgent but not emergent situation. I'm not gonna bring you in right now. So you better believe the minute my dentist's office reopens, I'm gonna be right in there, which is just a note to say everybody should be brushing and flossing every single day because it may be a while till we can go back to the dentist. We also have seen in a lot of places, mammograms and colonoscopies have been put off. Things that just can't be done by telemedicine, those have all been postponed. So we've seen cancer rates plummet in many parts, new cancer diagnosis rates plummet. We don't think cancer went away, we just think those people aren't getting diagnosed. And the later they get diagnosed, for many cancers, the worse their ultimate outcome might be. We also may see some chronic disease exacerbation. So for conditions like diabetes, for conditions like hypertension and heart disease, the inability to see a physician in person may actually exacerbate many of these conditions in ways we can't yet predict. And then finally, it's really important to talk about this fourth wave that we've already seen more than 10 suicides in healthcare practitioners as a result of some of the really significant mental health consequences of the work that's being done on the front lines. But we're also seeing significant mental health impacts on the general population. It is hard to be socially distant. We are fundamentally social beings. We want to be around the people we love. We want kids to be in school. We want to be able to celebrate birthdays in ways that don't involve car parades. We also know that people are experiencing a tremendous amount of economic injury. So as restaurants are closed and as all of these businesses are not being allowed to function, there's really significant economic impacts on people, which could also contribute to some mental health implications. So the last thing I want to sort of leave you with before I open it up to questions, this is a diagram that was created by two colleagues of mine, one at Harvard and one at Boston University, really trying to demonstrate until we have a vaccine, what are the things we can do that reduce the risk of coronavirus transmission, and particularly as the states begin to think about loosening some of these social distancing requirements, sort of what is the most safe and what is the least safe so that we can consider harm reduction approaches. The most safe is to be at home alone with your family and no one else. That may not be realistic. It's certainly not practical. None of us had enough food when this started in mid-March to get through without going to the grocery store and interacting with the outside world. So if you are going out in public wearing a mask, staying at least 6 feet away from individuals at all times, cleaning your hands, and minimizing the number of people. The other thing that's really important is considering ventilation. So being in an interaction with people outside in your front yard where you're at least 6 feet away is in all likelihood much safer than if you have those same 6 people come into your home, even if you're still maintaining that 6 feet of distance. Keeping interactions brief. In the state of California, we're really looking at about 15 minutes, which is completely arbitrary, but 15 minutes as the marker for whether or not it was long enough for someone to get exposed. And then, of course, don't share anything with anyone with whom you are not currently potting or bubbling as a result of this pandemic. So I think that is what I wanted to share with you. I just want to leave you with 2 final resources that may be helpful. CDC.gov does have tremendous information on their website. It's very deep. It takes a lot of time to navigate, but there is great information there. And then for the most current local information, it is publichealth.lacounty.gov, and they have their own COVID site as well. So those are 2 great places to be able to go to seek up-to-date information. And with that, that's everything I wanted to tell you. Now I'd love to answer any questions that you might have if I can.
Great. Thank you, Professor Shafir. So now I will start to convey the questions that we have for you, but that was very enlightening and we appreciate it. So I have a question here that says the latest statistics show that for the US, there are 1.5 million cases, 90,000 deaths, and 280,000 recoveries. What is the status of the other 1.1 million people?
So that's a great question. And my answer is, oh no. I think one of the problems we're having, for those of us in public health, the CDC has always been sort of the beacon, the bright light. And in this administration, the CDC has largely been marginalized, and yet they have the responsibility for data collection and for data cleaning and for data dissemination. Unfortunately, right now, they don't have good information. And part of that just may be due to the fact that they have been marginalized in this response. Part of that may also be due to the fact that most local health jurisdictions are so overwhelmed just in taking reports of new cases that they don't have time to close the feedback loop, and they don't have time to go back and ascertain what the status is of any given case. So my guess is we can feel more confident about the number of deaths. The number of people, sort of that missing million, some of them may still be hospitalized. We know that on average, people who require hospitalization are in the hospital for about 2 weeks. So some people are in that bucket. Some people are missing people that nobody ever closed the feedback loop to figure out what happened. But my suspicion is most of them are either recovered and we just don't have that data, or they're still hospitalized and we're awaiting news of their outcome.
Okay. The next question is, can you talk a bit more about contact tracing? Tell us a bit about how that's done.
Sure. And for those of you who are interested, the state of California is looking for volunteers who are willing to participate. So contact tracing actually started in the United States in the 1930s as a response to sexually transmitted infections. So, and at the time we called them venereal diseases. I wasn't alive in 1930. At the time they were called venereal diseases. But when an individual was diagnosed with a sexually transmitted infection, there would then be someone from the health department who would contact them and say, I need to know everybody with whom you have had sexual contact, so we can now find them and encourage them to be tested. And the big reason for that is a lot of the sexually transmitted infections don't manifest symptoms, and yet they can cause really significant damage. So what we are trying to do in the United States with this idea of contact tracing, when someone is diagnosed with COVID, we know that we need to figure out where they potentially went in the population and with whom they would have come in contact. So for example, let's say I went over to Helene's house yesterday for coffee. I didn't, but let's say I did. And then it turns out that today I got diagnosed with COVID. So a contact tracer would then have the responsibility to call Helene and say, listen, you've been exposed to someone who was diagnosed with COVID. Because you've been exposed, we now need you to quarantine for the next 2 weeks to see if you develop symptoms. And we're going to tell you a lot about the potential symptoms about which you need to be aware. And we're going to let you know about the resources that might be available to support you So whether you need food or you need to be linked with medical care, we'll do that. And then constantly check in with those people to see if they have developed symptoms. And if they have, now asking about their contacts. So really trying to manage the transmission of the virus using a much more targeted approach. You know, right now, our approach is just saying everybody could have it, so everybody needs to stay home. Contact tracing will allow us to say people can come into contact with one another if we have a way to know sort of where virus is being transmitted as close to real time as possible.
And can you expand on what the shortage of contact tracers out there currently is?
Yeah, so as you can imagine, it takes, first of all, the training in California is about 20 hours long to figure out how to do this. And we are trying to build a workforce of 20,000 contact tracers. But if you think about that, we now have to get people through 20 hours of training. We can't do it in person, so everything has to be done virtually like this. And it's not just, does someone know, you know, here's the incubation period and this is what isolation and quarantine mean. We also have to really rely on motivational interviewing and some very sensitive questions that may be asked. So we have to train people to feel confident that they can ask questions and get honest answers. And even before that, that they can successfully initiate a contact, right? No one has you have a moral obligation to participate, but no one has a legal obligation to give their information to a contact tracer. So we really need to train people to say, your information will be kept safe. Here's why this is important on a population level. Here's what we're going to do and provide you resources, and here's what you need to know. So there's a lot of training that needs to be done. And historically, we've really only used contact tracing for sexually transmitted infections and a little bit for tuberculosis. So we just don't have a workforce that has previously been trained to do this. And we have a massive need. And then beyond that, every local health jurisdiction, so Los Angeles County Department of Public Health may be doing it a little bit differently than San Bernardino. So not only do people have to be trained sort of in the virus and in the techniques of contact tracing, they then have to understand how to integrate into the local health department that's going to be utilizing that information.
Wow. Okay, so we have another question. Can you give us an idea of how quickly this vaccine is being developed relative to a typical situation, and how have we been able to speed up this process?
Great question. So in a typical situation, well, let me take a step back. I don't think there is a typical situation. You know, we've had some vaccines that they've made remarkably quick progress, and it's been 5 or 6 years. But we also have diseases like malaria that we've known about for hundreds of years, and there's no vaccine, and it doesn't look like there is one on the horizon. Whereas with an Ebola vaccine, they've been working on it for less than a decade, and there's already a candidate that appears to be safe and may have some level of effectiveness. So typically, you know, we talked about that phase 1, phase 2, phase 3 process. Typically what happens is they have to identify some sort of immunologic target, so something to which the body can respond. In the case of SARS-CoV-2, in the case of COVID, we're not even 100% certain if people do develop these antibodies. The two viruses that are related to SARS-CoV-2, related to COVID, that cause very serious disease in humans are SARS and MERS. And for SARS, it looks like people develop these antibodies that last for at least a decade, so that's good news. The problem is that there are a whole bunch of other coronaviruses to which COVID is related that cause those colds that we all get every year. For those of us who are parenting toddlers, we get them 7 or 8 times every year. And the reason you get them year over year is because any immunity that you build goes away. It doesn't last that long. So the first question that has to be answered is, do people really develop those antibodies that are protective, and do they last? I think the next thing will then be what sort of the approach. And there are a bunch of different approaches for virus vaccines. You can kill the virus. So put it in formalin or formaldehyde, that kills it. We know those are safe because they can't replicate and create more virus, but they also tend to be a little bit less effective. Maybe they'll weaken the virus. Maybe they'll just use a protein, or maybe they'll just use the molecular information. So different teams are trying to take different approaches and trying to figure out what is sort of the right approach to ensure that the body mounts an immune response. The other thing that's really being considered is what is the absolute least amount of vaccine that can be given to any individual person to induce immunity, because we know we're going to have such a shortage when the vaccine is first developed. So for example, that Moderna vaccine that we talked about, which is an RNA-based vaccine, they tested 25 nanograms and 100 nanograms. Turns out with the 100 nanograms, it appeared as if there were some adverse reactions, like a lot of redness and inflammation at the injection site. With the 25, they're not sure it's effective enough. So now they're going back to test sort of the 50. So what's the least you can give that's still safe and still effective? There's a great resource on the New York Times that sort of shows what are all the steps that can be shortcut in order to speed up the availability of a new vaccine. And it's pretty much, if we shortcut every single step, we could have a vaccine in 2021. But some of the estimates are that it may be 10 years before we have a vaccine if we're not willing to sort of build upon the existing science and do some of the studies in a way that previously we would not have done. I'm optimistic that it could be 2021 before we have a vaccine. And then the question is, how do we distribute that vaccine, and how do we make enough, and how do we distribute it in an equitable way?
Okay.
I'm sorry, I'm not a lot of good news today, am I?
Oh, well, this virus really presents challenges on all fronts. So there are a lot of unanswered questions, I'm sure. But here's the next question. Do you have any information on the use of synthetic antibodies to treat COVID?
So that's a great question. And there are a number of trials around the world that are looking at synthetic antibodies. So do I have any definitive information? I don't. But is this one of the approaches? Is it going forward in clinical trials? Is there at least a theoretical basis that it could work? Yes, absolutely. And I think at this point, I think it was Tony Fauci who said you have to take a lot of shots on the goal. And that's pretty much what's happening. Everybody's working every different approach. Maybe synthetic antibodies, maybe convalescent plasma, maybe an RNA vaccine, maybe a live virus, but just go, because we don't know what's going to work right now.
You just mentioned convalescent plasma. Can you tell us a bit more about where that stands? Because we've heard some of stories on the news, but not definitive.
Yeah, so convalescent plasma is an approach that has been used for viruses before we had vaccines. So for example, there used to be a lot of convalescent plasma for mumps. We use convalescent plasma for rabies because it's such a terrible disease. We want to make sure that we're not leaving people vulnerable. So it does have a long history of successful use. Essentially, you take someone who has been infected, who has recovered, you test to see what their levels of antibodies are. So do they have sufficient levels of protection that we think it's worthwhile to take their blood? Then they filter it out so that they're only giving these protective antibodies, and you transfuse them into another person. Certainly the news had a very promising story from someone who received convalescent plasma at UCLA, who was on mechanical ventilation, who was very, very sick, who received the plasma, and very shortly thereafter began to recover. So these are still in clinical trials where they're randomizing people. And the big idea there is when someone receives convalescent plasma and gets sick, such as the story that was recently in the news, receives the convalescent plasma and gets well, we don't know if that's someone who was going to get well anyway and they happen to receive convalescent plasma, or if they got well because they received convalescent plasma. And that's really that's the magic of epidemiology, trying to figure out, are the things that we're doing causal? Are they responsible for the outcomes? And that's why we rely on those randomized trials, because they help to balance a lot of the other factors that may have influenced outcomes. So I think we probably will have some results within the next few weeks. But until then, convalescent plasma is being used. It's called an emergency use authorization. So the FDA can say, we're not sure if this works, but since we don't have anything else, you can use it right now. So there is an emergency use authorization for the drug remdesivir. There's one for hydroxychloroquine, and there's one for convalescent plasma. So right now, I think it's probably better than nothing. And convalescent plasma does tend to be fairly low risk, as opposed to giving a drug that might have side effects.
Mm-hmm. Okay. So I have a question that's personal, but I might also be speaking for others. Many of us have family and children and grandchildren who live at a distance, and it's currently not likely that we're going to be traveling to visit them anytime soon. Do you have any thoughts about when we will be able to resume travel to see people that we would love to see?
Yeah, so my husband and I the two questions in my house right now are when is childcare going to open, and are we going to send our kid back? My answer is yes, no matter what, no matter when, yes. And then the other question, both of our mothers live out of town, and they're doing a tremendous job with social distancing, but we're getting a lot of when can we come? When can we visit? And so that's a near constant topic of conversation in our house as well. It depends, which is, unfortunately, it's like the motto of the epidemiologist. It depends. If you're talking about someone that you could visit driving, and you don't have to get on a plane or a train, if you are going to visit someone who is socially distant to the same extent you are, the idea there is maybe you create sort of a pod or a bubble. I saw this cheekily referred to as quarantines. So who are the people with whom you are going to socially distance, even if you're not living in the same physical location? So in that circumstance, if you know that they are taking their socially distancing to the same level of seriousness as you, if your grandkids, for example, are not going to a day camp, they're not going to school, they're not going to childcare, not doing any of those things that would bring exposure to a lot of people at one time, I think if you can drive there and not stay in a hotel, so you're really limiting exposure, it's ultimately a personal decision. But I think if plane travel, if hotel stays, if any of that is required, I think potentially it's going to be until we have a vaccine or until we have an effective treatment that it will be wise to engage in any of those things.
Okay.
Now, if any of you are looking to borrow a grandchild, I have one. He is very cute. He's in the terrible twos, so maybe I'm not selling that appropriately, but I loan him out. Happy to loan him out to anyone.
Okay, we do have another question. What are some of the countries that are working as vigorously as we, and do we have a fluid exchange of information with them?
Oh, that one's tough. And you may have been keeping up with the statement that was made on Twitter, which is, I guess, how our government now releases information. But the president did send a statement to the World Health Organization, which is currently having its international meeting, although for the first time they're doing it virtually. So the same way we're doing this, the World Health Organization is meeting. There is a tremendous amount of research that's being done throughout much of Asia. South Korea in particular is doing fantastic work. There's a lot of work that's being done in the UK. There's a lot of work that's being done in Australia. But unfortunately, the United States is being pretty difficult with respect to international collaboration. So, for example, the WHO is conducting an international trial that's called the Solidarity Trial that is looking at testing some of these treatments. And it's being done in countries around the world, and the United States essentially said, we're not going to participate. Likewise, the president, other countries have said they're going to make collaborative agreements that when a vaccine is brought to market, they're going to think about how to equitably distribute the vaccine throughout the world. And meanwhile, right now, the United States, President Trump has said, when we have a vaccine, we're only going to give it here. It's only about the United States. So I think unfortunately, public health and infectious diseases have been politicized to just an unprecedented level. And one of the things that we're seeing is that may leave us very isolated in the global community.
What is the likelihood that a vaccine that's developed is going to be affordable to the rest of the world?
So that's a great question, and it's one of the things that has been it's one of the things that's been talked about every time a vaccine is developed. So, for example, as they're talking about an Ebola vaccine, you know, if we were to get a vaccine and it's $5, we would all celebrate because what an affordable vaccine that is. But in most sub-Saharan African countries, $5 is more than they're spending per person per year on health. There are some organizations, for example, Gavi, the global, well, now that I've mentioned it, I can't remember what it stands for, the Global Alliance on Vaccine Initiatives, I think. And one of the things Gavi does is they raise funds to make sure that vaccine can be made available to everybody throughout the world, regardless of their ability to pay. There are groups like PATH, which has a tremendous footprint in global health. The Gates Foundation, which subsidizes the cost of critical vaccines. Rotary International, which has been providing the majority of polio vaccine. So my guess is, regardless of how affordable the vaccine is, when it's developed by the manufacturer, there are a lot of players that will step in to ensure that everybody can receive the vaccine regardless of ability to pay.
Mm-hmm. And lastly, what is the time frame in which, if we had a vaccine, that it could be administered around the world logistically? What would be the time frame in which that might happen?
Yeah, I mean, I think, so if you think about it, we have about 330 million people in the United States. And then the question is, number one, how quickly can we make 330 million doses? And number two, how do we organize infrastructure to get that out? Maybe it's things like, I don't know if any of you have participated in drive-through flu shots. So maybe we have sort of those points of dispensing and drive-through opportunities, or maybe like what's been done in many countries. So for example, most countries that have socialized medicine, all of the children get their vaccines, certain vaccines at school rather than through the health system, because everybody's going to get one. So you might as well do it when everybody's in school. So maybe we look at strategies like that. That helps us cover the under 18 population. And then we think about, what do we do? We can certainly lean on the experiences that we've had globally with respect to smallpox eradication, where you send teams out with vaccine. And for example, when we talk about polio, which is a disease that was on target for eradication, that unfortunately has backslid because of inability of people to vaccinate, they would and do organize national immunization days where you have 90,000 people across a country who are all responsible for vaccinating a small community. We certainly would need more than 90,000 in the United States to vaccinate everybody on one day. It will require a massive infrastructure, but we do have previous examples of success that we can learn from in order to get the vaccine out to as many people as quickly as possible in a way that's equitable.
Okay. Well, unless there are any other questions from the chat room, I think that pretty much completes the series of questions we received. And I do want to thank you very much, Professor Shafir, for being with us today and enlightening us. I've learned a tremendous amount, and I'm sure we all have. And so now I'd like to turn the program over to Shirley Ho, our outgoing president. But before I do that, I want to thank her for her excellent leadership of the Faculty Women's Club Board this year, and especially during this unprecedented and challenging time. You have done an amazing job, and you are a terrific leader. And Shirley, on behalf of the board, thank you very much for all you've done to lead us through these difficult times.
Thank you, Helene. And thank you, Dr. Shafir, for your excellent presentation. Thank you all participants for your presence and support. Special thanks also go to Dr. Julie Sina, Associate Vice Chancellor, Alumni Affairs. Sia Ford, Senior Director, Professional School and Affinity Programs, UCLA Alumni Association. Then is Justin Seiler, Assistant Director, Professional School and Affinity Programs, UCLA Alumni Affairs. Helene Derozal for her coordinating efforts to make our first virtual event possible. Then I want to thank FWC, all board members, for their dedication and hard work to make this year a very, very special one. I think Justin, he just muted for all of us. So ladies and gentlemen, please give all of them a warm round of applause.
Water, but
Here I am.
Okay. Now, effective from July 1st, Betty Billett will be our new president. So Betty, can we see you? Can we hear you? Betty, can we hear you? Anyway.
I hope so.
We wish FW. Oh, good, you're there, thank you. So we wish FWC continued success through the leadership of the 2020 to 2021 new board. We will get through this difficult time together as a team. Be sure to stay safe and healthy, and we look forward to seeing you soon. Thank you so much. Now, please press the leave button to end the meeting. Thank you very, very much. Can you talk? You can talk a little bit. I can hear you. Okay. Okay, the meeting I think is ended.